Welcome to Neuro News. Today, we're exploring acoustic neuroma, also known as vestibular schwannoma, a benign but impactful brain tumor that affects balance, hearing, and sometimes more. Whether you're a curious listener, a medical student, or a resident brushing up on your knowledge, this is for you. An acoustic neuroma is a non-cancerous tumor that develops from Schwann cells, which insulate the vestibulocochlear nerve, the nerve that carries sound and balance signals from your inner ear to your brain. While these tumors are typically slow-growing, their location at the cerebellopontine angle can cause serious symptoms by pressing on nearby structures, including the brainstem and cranial nerves. Most cases are sporadic, but in around 5% of patients, they are linked to a genetic condition known as neurofibromatosis type 2, which often leads to tumors on both sides. The most common symptom is gradual hearing loss in one ear. Over 90% of people with acoustic neuroma report this. Some even experience sudden hearing loss. Other symptoms include tinnitus, which is that annoying ringing in the ear, balance issues or unsteadiness, especially in the dark, vertigo, though this is less common, and when the tumor grows large enough, it may press on the trigeminal nerve, causing facial numbness, the facial nerve leading to weakness or even paralysis, the cerebellum causing coordination issues. Early detection is key. A basic hearing test, or audiometry, can identify sensory neural hearing loss. But the gold standard for diagnosis is an MRI with contrast. It shows the tumor clearly in the internal auditory canal or the cerebellopontine angle. In some cases, auditory brainstem response testing or CT scans may be used when the MRI isn't available. So, what can be done? Treatment depends on the tumor size, the growth rate, and patient factors such as age and hearing status. There are three main approaches. First is observation, especially for small tumors or older patients with minimal symptoms. Regular MRIs are used to track growth. Second is surgical removal. There are three main surgical routes. First is the retrosigmoid approach, which may preserve hearing. Then is the translabyrinthine approach, which is preferred for non-hearing patients. And lastly, a middle cranial fossa approach, which is used when hearing preservation is crucial. The last thing, number 3, is stereotactic radiosurgery, like a gamma knife or a cyber knife. This is a non-invasive treatment measure and is ideal for tumors that are small to medium size or for patients who cannot undergo surgery. Remember, each treatment has risks, most notably hearing loss or facial nerve palsy, and balance problems. Acoustic neuromas don't spread, and many are slow growing, but their location means monitoring is critical. After treatment, patients undergo routine MRI follow-ups to check for recurrence or progression. Rehabilitation may include balance therapy, hearing aids or cochlear implants, facial therapy if nerve function is affected. In neurofibromatosis type 2 patients, management is more complex due to multiple tumors. A multidisciplinary approach with audiologists, neurosurgeons, and genetic counselors is often required. So, in conclusion, acoustic neuroma may be benign, but its effects can be life-changing. Thankfully, modern imaging and treatment techniques offer excellent outcomes when diagnosed early. If you or someone you know experiences unilateral hearing loss, persistent tinnitus, or balance problems, Don't ignore it and consult a specialist. Thank you for joining us. Stay informed, stay proactive, and take care of your health and your hearing. Have a blessed day.